All right, let's talk about pulmonary embolism. This is one of those diagnoses where you absolutely have to be on your A game. I mean, get it right, and you literally save a life. But if you miss it, well, the consequences can be catastrophic. So today, we're going to break it all down, high-yield style, so you know exactly what to look for.
So let's just dive right in with the most important concept. I want you to think of the lung as a giant filter. It's a brilliant system, really. Its job is to catch all the junk from the venous system before it has a chance to get to the arterial side and cause a stroke or something worse. A pulmonary embolism, or PE, is what happens when a big blood clot gets past everything else and clogs that filter. And make no mistake, this isn't just a breathing problem. It's a full-blown cardiopulmonary emergency.
So here's our game plan for today. First, we'll talk about the clogged filter, what's actually going wrong. Then, we'll trace the journey of that clot. After that, we'll figure out what the patient actually looks like, how to work them up, and finally, how to manage them, with some key pearls at the end. Let's do it.
Okay, first up, the clogged filter. We're going to look at the nuts and bolts of how this simple blockage just completely wreaks havoc on both the heart and the lungs.
I want you to picture a garden hose, and then imagine someone suddenly stomps on it. What happens? The pressure behind that spot just skyrockets, right? Well, that's exactly what's happening in the pulmonary artery. The embolus slams in there, creates this acute obstruction, and causes a massive, massive backup of pressure.
And all that pressure has to go somewhere. It backs right up into the right ventricle, the RV. Now, you have to remember, the RV is, well, it's kind of wimpy. It's a low-pressure chamber that's designed to pump blood into the low-resistance lungs. It is not built to pump against a brick wall. So it starts to stretch, it gets strained, and it can fail fast.
And this brings us to a really classic clinical question, something that trips a lot of people up. Why are these patients so desperately short of breath, so hypoxic, when you put your stethoscope on their chest and their lungs sound perfectly clear?
The answer, in 2 words, is VQ mismatch. So let's break that down. The V stands for ventilation. Air is getting into the tiny air sacs, the alveoli, just fine. No problem there. That's why the lungs sound clear. But the Q, which stands for perfusion, or blood flow, well, that's blocked. The blood can't get to those perfectly good air sacs to pick up any oxygen. So you have all this air, but no blood flow to it. We call that dead space, and it's why these patients become so profoundly hypoxic.
All right, that's the what. Now for part 2, the path of the embolus. Let's actually trace this rogue clot from where it starts all the way to where it ends up.
So the journey almost always starts deep in the legs with something called a deep vein thrombosis, a DVT. A piece of that clot breaks off, and then it's off to the races. It travels up the huge inferior vena cava, goes straight into the right atrium, gets squeezed through the right ventricle, and then, bam! It gets shot into the pulmonary arteries, where it finally gets stuck. It's basically a projectile aimed right at the heart of the lungs.
And you know, it's really important we get our words right here. A thrombus is the original stationary blood clot. It's the source of the problem, usually sitting quietly in a deep vein. The embolus is the piece that broke off and is now on the move. That's the missile. The thrombus is the launch site. The embolus is the missile.
So you might be asking, why do these clots even form in the first place? Well, the answer is a classic concept called Virchow's Triad. It's basically a recipe for making a clot, and it has 3 ingredients. First, stasis. That's just slow-moving blood, like when you're stuck on a long flight. Second, hypercoagulability, where your blood is just stickier than normal, which we see in things like cancer or with birth control pills. And third, endothelian injury, which is just damage to the blood vessel wall itself, like from a major surgery or trauma. Get any of these and your risk goes way up.
Okay, so we know what it is, we know where it comes from, so what does the patient actually look like when they show up in the ER? That brings us to part 3, the clinical picture.
The key word here is sudden. This stuff happens out of the blue. The #1 complaint by far is dyspnea, sudden shortness of breath. They might also complain of pleuritic chest pain. That's a really sharp pain that gets way worse when they try to take a deep breath. And if you see them coughing up blood, hemoptysis, or if they actually passed out, syncope, those are really, really ominous signs.
Now, when you actually go to examine them, there are 2 signs that are just screaming PE. The single most common sign is tachypnea. They're breathing fast, more than 20 breaths a minute. And the second most common is tachycardia. Their heart is racing, over 100 beats per minute. You might also find a little low-grade fever. And don't forget to look at their legs for signs of a DVT. You know, one leg that's swollen and painful.
So, the alarm bells are ringing. You suspect a PE?
Now you have to prove it. This is part 4, the diagnostic workup. This is how we go from a hunch to a confirmed diagnosis. Now, you don't just immediately rush every patient to a CT scan. You start by figuring out how likely this diagnosis actually is. And we use a tool for that, a clinical calculator called the Wells criteria. It gives points for different things like, do they have signs of a DVT? Is PE the most likely diagnosis? Is their heart rate over 100? You add up the points, and it tells you if the patient is low, moderate, or high risk. And that score tells you what to do next. For those low-risk patients, our next move is often a blood test called the D-dimer. And there's a fantastic saying for this test that you should burn into your memory. It is excellent for ruling out, but terrible for ruling in.
So what on earth does that mean? Well, the D-dimer test has what we call high sensitivity. In a low-risk patient, if that D-dimer comes back negative, you can be almost certain they do not have a PE. You can safely rule it out and look for other causes. The problem is it has very low specificity. That means a positive result could be from anything: recent surgery, pregnancy, cancer, and infection, the list goes on. So a positive test doesn't tell you they have a PE, it just tells you you're not done yet. You have to keep looking.
Okay, what about the ECG? Everyone remembers from medical school the S1Q3T3 pattern. And yeah, it's the textbook classic sign of right heart strain, but here's the secret: you almost never see it. The most common ECG finding in a PE, it's way simpler. It's just sinus tachycardia, a fast heart rate. That's the high-yield fact you need to know for your exams and for the wards.
Now, let's take a quick detour to talk about a really special population: pregnancy. Diagnosing a PE in a pregnant patient is, well, it's a huge challenge. Why? Because pregnancy itself is a prothrombotic state. It basically checks off all the boxes of Virchow's Triad, so their baseline risk is already way up there.
And when you do suspect a PE, choosing the right imaging test is tricky. You've got two main options. There's the VQ scan, which gives less radiation to the mother's breast tissue, so it's often preferred if their chest X-ray is totally normal. But then there's the CT pulmonary angiogram, the CTPA, which is generally more accurate. It gives more radiation to the mom, but interestingly, less to the fetus. It's a complicated risk-benefit discussion you have to have.
But for pretty much every non-pregnant patient, the choice is a lot clearer. The gold standard, the definitive test for diagnosing a PE, is the CTPA. This is the test where we can actually see the clot, plain as day, sitting right there in the pulmonary arteries. It gives you the answer.
All right, let's bring this all home. We found the clot, now what do we do? Part 5 is all about emergency management and pearls, how we treat it, and the key things you have to remember.
Okay, management has to be fast. First things first, support the patient. Give them oxygen, give them IV fluids if their blood pressure is low. Step 2, and this is absolutely critical, start anticoagulation, blood thinners, immediately. Sometimes you'll even start it before you have the CT scan back if you're really suspicious. That's usually with heparin. Then you'll transition them to a long-term oral pill. And for those really sick patients, the ones with a massive PE who are in shock, you have to think about thrombolysis, the big gun clot-busting drugs.
So let's lock this all in with a rapid-fire review. These are the pearls. 1, sudden shortness of breath plus a fast heart rate equals PE until you prove it's not. 2, the lung is a filter. 3, use the Wells score to figure out your risk. 4, D-dimer is for ruling out, not ruling in. 5, the most common ECG finding is simple sinus tachycardia. And 6, CTPA is the gold standard.
And that's a wrap. So I'll just leave you with this one question to think about, to really make it stick. After hearing all this, what is the single most important diagnostic clue for a pulmonary embolism that you are never, ever going to forget?